invitation from President of Association of Physicians of India and President of Association of Physicians of Bangladesh. Sir, may I start the program?
Okay, sir, go ahead.
Okay. Good evening, respected President API Professor Kamlesh Tiwari, President API Professor Rafiqul Alam, senior faculties from Nepal, Professor Sanjeev Sharma, Professor Mahesh, Dean Indian College of Physicians, Dr. Rajesh Upadhyay, my colleagues, Professor Udas Chandra Ghosh, Professor Jayanto Panda, Dr. Palani Appan, Professor Nandini Chatterjee, and Dr. S.M. Arafat. He is yet to join. He is the secretary.
I am here.
Oh, okay. Welcome. Dr. Arafat, he is the chairman of Department of Medicine of Bangabandhu Sheikh Mujibur Rahman University College and also secretary of APB. And all my students connected here in the panelist and delegate league, Dr. Monishankar, Dr. Purvasha, Dr. Manali, Dr. Himatri. Good evening, everybody. Today is a historic moment in academic history of this subcontinent. This subcontinent has a rich cultural heritage of more than 5,000 years. This is the birthplace of intellectual thought. In other words, I can say philosophical ideas, which ultimately translated into science without giving much recognition to our contribution. Due to richness of this land has been an object of innovation from ancient period. First from Aryans, then Greeks, then Persians, Hun, Shak, Afghan, Mughals, then Europeans. Uniqueness of this subcontinent is it has accepted all and amalgamated and give birth of a very rich civilization of India, Bangladesh, Nepal. And this rich civilization has evolved from the amalgamation. So it is the amalgamation, even in the academic field, which can make us rich and world leaders. In different informal meetings, we members and our senior leaders from neighbor countries, we felt that we should have a common forum, a common platform to share our knowledge and experience. But anyhow, we lacked to form a structured forum of this need. I am thankful to my mentors, President API, Dean Indian College of Physicians, to give me encouragement for such an initiative. And when we discussed with our counterparts in Nepal, Bangladesh, and Sri Lanka, they readily accepted and showed their willingness to join in such a platform and carry out such an academic activity with hope that day will come when we will be the world leader in the academics. With Bangladesh and West Bengal, previously we had such a common program, maybe due to our geographical proximity and same language, same culture, but it was lacking in the country level. Today is a historic moment. We are together and committed to develop this subcontinent a academic leader in the globe in future. With this few words, in the inaugural ceremony, I request Professor Kamlesh Tiwari, President Association of Physicians of India, to give few words and to motivate us. Professor Tiwari, please.
Thank you, Dr. Jyotimay. Dignitaries from Bangladesh, Nepal, and my colleagues, especially Dean Dr. Rajesh Upadhyay, Dr. Palani Appan, and other friends. Actually, this is a good initiative by Dr. Jyotimay Paul, who has connected us with Bangladesh and Nepal for the teaching purpose. Dr. Jyotimay has given us a good concept of our civilization and culture, but in teaching program, if we will connect to each other, that will be a better idea. And I think we are going on a better way. I am sure that this CME is going to be a marvelous one on many fronts, and I wish a good success for this type of meeting and this CME. Thank you very much. Thank you.
Thank you, sir. Thank you. Now I request Professor Rafiqul Alam, President of Association of Physicians of Bangladesh, to say a few words for this initiative.
Thank you, Professor Jyotirmoy Pal. Good evening to all of you from India, Bangladesh, and Nepal. And I am especially mentioning the name of Professor Kamlesh Tiwari, President in Association of Physicians of India, Professor Rajesh Upadhyay, Dean, Indian College of Physicians, Professor Jyotirmoy Pal, Vice Dean, Indian College of Physicians, Professor Mohesh from Nepal, Professor Udas, Professor S.M. Arafat, and Dr. Y.P. Mangal, Professor Jayant Kumar, and all others. Please take my greetings on behalf of Association of Physicians of Bangladesh. I especially thank Professor Jyotirmoy Pal and Professor S.M. Arafat for their endeavor to materialize this meeting. Hopefully, this will be a wonderful meeting for the young physicians of the subcontinent, and I am looking forward to seeing it as a form of in-person meeting of all SAARC countries, especially the young physicians of all SAARC countries in future, if Almighty permits us and if the pandemic is over. We will be very happy to meet in person, because this sort of meeting, especially for Bangladesh, will be very useful. We can learn a lot from our Indian friends and other friends of the different countries of the subcontinent. Once again, I thank Professor Jyotirmoy Pal for his great effort for this meeting. I congratulate all of you. I thank and congratulate the participant of the scientific session, the presenter, the moderator. Maybe I will not be with you for a longer time because I have some obligation in my hospital. So thank you very much. See you again.
Thank you, sir. Thank you. We are missing Professor Y.P. Munjal. He is a mentor of our AKI. Now he is acting as the director of Physician Research Program due to his ill health. Anyhow, he conveyed his blessing towards program. Now I request Professor Sanjeev Sharma. He is a professor of medicine of Institute of Medical Science, Dharan. He is a senior professor and academician from Dharan, Nepal. I request Professor Sanjeev Sharma, please say a few words.
Thank you, sir. Thank you, everyone. Namaskar. First of all, I like to congratulate Professor Jyotirmoy Pal sir for initiating this wonderful initiative. I think doctor itself means teach, and teaching learning activity is so essential to keep us updated. And it's very, I always take it as a fortunate job to imbibe and disseminate knowledge to our junior colleagues. Thank you, sir, for this wonderful initiative. And especially, I am very fond of AKI, and we are also working in the community level to prevent AKI, and especially in collaboration with International Society of Nephrology, and had an opportunity to work with very famous Professor Mehta from California University. So I look forward this collaboration, and I thank you all the dignitaries. I could see Professor Sakuja sir and Alam sir from Bangladesh and other dignitaries, API President Kamlesh sir, and thank you. And I'm also happy to see that Dr. Mahesh, Professor Mahesh joining this forum. All the best to those presenter, and we hope to learn from this endeavor. Thank you very much, sir.
Thank you, Dr. Sharma. Actually, last November, when I visited Dharan to take exam, that time you and me discussed first time for such initiative. Then I called Arafat to get his consent. Now I request Dr. Rajesh Upadhyay, Dean of Indian College of Physicians, to say a few words.
Good evening, everyone. My API President, Dr. Kamlesh Tiwari, President of Bangladesh, Dr. Alam, Dr. Sharma from Nepal. I really congratulate and thank Dr. Jyotirmoy Paul for this great initiative whereby we've been able to connect with you all in Bangladesh and Nepal, and the objective is common: teaching and learning, particularly aimed at the postgraduate students. I'm sure this program is going to be a great success and a great learning experience for everyone. I really would like to thank the presenter and the opening batsman for today's meeting, the young Dr. Bhattacharya, Dr. Sakuja, who's the main discussant, all the chairpersons who are there. These are people who are dignitaries, who are luminaries of the Association of Physicians of India. And I'm sure this program will be a great learning experience. I wish this program a great success.
Yes, thank you, Dean sir. Now I request Dr. Sohail Mohammad Arafat. He's a professor and chairman of Department of Medicine, Bangabandhu Mujibur Rahman University of Medical Sciences, Dhaka, Bangladesh. And he is also secretary of Association of Physicians of Bangladesh. Sir, please say a few words.
Very good evening to everyone. Today is really historical day. At the very outset, I'd like to congratulate the combined effort, the leaders of the combined teams of API and APBs, and also from Nepal, especially our respected president of API, Professor Kamlesh Tiwari, and from APB, the chairman, President Professor Mohammed Rafiqul Alam. My very good friend, Dr. Jyotirmoy Pal, today's program is the brainchild of him, and we are very happy to be with this effort. I guess this effort is not just a beginning. We have to go further, maximum possible. If we move together, we can reach further. That is the basic philosophy. We have to enrich our younger generations to improve their knowledge and skills so that they can fight in the international arena as well. So with these few words, I'd like to thank the organizers, and hopefully the best wishes to the presenter. And to my friends, I'm seeing on the screen Panda, Dr. Udas Ghosh, and a lot of friends are here in the screen. Best wishes to everyone. Thank you very much.
Thank you, thank you. Now I request Professor Vinay Sakuja. He is a pioneer in the field of nephrology in this subcontinent, and is the emeritus professor from the PGI Chandigarh. Sir, say a few words and give us blessing.
Thank you. Thank you very much. At the outset, I'd like to convey my thanks to Professor Jyotirmoy Paul for this kind invitation to participate in this program this evening. So many thanks to you for having taken the initiative and made the efforts to organize this. I hope all the faculty members and the students who are attending this program will enjoy it and learn from it. So I think we can now go ahead with the presentation by Dr. Manishankar Bhattacharya.
So first, let me introduce the team.
Okay.
So today's issue is the acute kidney injury. This is a case-based discussion. We thought we should go away from the direct lecture to the more a case-based, more a problem-based, more a issue-based discussion and direct interaction between the teachers and the student. So in the Dr. Manishankar Bhattacharya, he is the postgraduate trainee and MD in RGKar Medical College, Kolkata. He will present the case. Also, I have kept 3 more students. Dr. Purvasha Mishra is a 3rd-year student from the medicine from my college. Dr. Manali Chando, he is a 3rd-year PG from Calcutta Medical College, and Dr. working under Professor Udas Chandra Ghosh. Another Dr. Himanti, he is also 3rd-year PG student from SSKM Hospital, working under Professor Nandini Chatterjee. And we have faculties along with you, Professor Mahesh, and he is a nephrologist from Kathmandu. We have Professor Jayant Panda, he is the chairman and professor and head of SCM Medical College, Cuttack. We have Professor Udas Chandra Ghosh, he is a professor of medicine from Calcutta Medical College. Dr. Palaniappan, he's a consultant physician from Madurai, Tamil Nadu, and along with Dr. Arafat, Professor Nandini Chatterjee is the professor of medicine and the associate of SSKM Hospital and associate editor, Journal of Indian Medical Association. So with this brief introduction, now I first request Dr. Monishankar Bhattacharya, you share your screen and start presenting the case.
Okay, sir. Sir, am I audible?
Yes, yes.
Okay. Thank you, sir. Good evening, sir. Today, myself, Dr. Monishankar Bhattacharya, postgraduate tenure of Arjikar Medical College and Hospital, is going to present a case of acute kidney injury. At first, before we go into the details discussion of the cases, at first we have discussed the case scenario when a patient presented an emergency. A 58-year-old female presented with altered sensorium and breathlessness at emergency, according to her family member, for her last 18 to 24 hours, and she had without any history of trauma, vomiting or diarrhea. Though she had a history of fever for last 5 days, along with decreased urine output for last 2 days, as per her family member. On rapid assessment at emergency, patient has altered sensorium. On assessment by the Glasgow Coma Scale score, the score was 9/15. Pulse is low volume and 96 per minute with hypotension, and saturation is 98% with nasal prong, and respiratory rate is 22 per minute. Emergency investigation of ECG and NCCT brain does not reveal any significant changes. At emergency, on the arterial blood gas analysis that reveals the metabolic acidosis with low pH, with low bicarbonate, high lactate, and the high potassium level. Foley's catheterization done at emergency and around 30 ml urine collected. On examination, she had a cold column extremities with signs of poor hydration without any features of volume overload. Emergency laboratory investigations, including complete blood count and the renal function test, reveals the total high level of total leukocyte count with neutrophilic dominance and high level of urea and creatinine. At emergency, on the basis of this short history and this short rapid assessment and investigations, our primary impressions is a patient presented with a septic shock with acute kidney injury.
Monishankar, wait, please.
Yes.
Thank you for your presentation. You have mentioned the patient is suffering from acute kidney injury, AKI. So how do you define AKI? Can you tell me?
Sir, according to the old definition, sir, there is a kidney dysfunction, acute dysfunction of kidney over days to weeks that will reveal in that will causes the deposition of nitrogenous waste product and causes the disequilibrium of ECF and body electrolytes. And according to the new definition, there are some criteria as per the creatinine and the urine output.
No, just a minute. So you said days to weeks. Would you like to
sorry, sir. Hour to days.
Hours
sorry,
to...
hour
yeah,
to days.
that's very important.
Yes, sir. Yes, sir.
It has to be hours to days.
Hour
supposing
to days.
Supposing it is days to weeks, what would you call that?
Sir, rapidly progressive renal failure.
Yeah, so that is a totally different term that we should use if it is days to weeks.
Yes, sir.
So don't mix up the two terms completely.
Yes,
even though the word rapidly progressive is part of RPRF, however, in AKI, it is over hours to days. In other words, it is more rapidly progressive than in RPRF. All right, the sequence of events is more rapidly progressive in AKI as compared to RPRF. So this point should be absolutely crystal clear.
Yes.
Right?
Sir, one thing I just asking you, because when we are student, we actually, this word is not there. AKI was not there. We actually used to read as a ARF and TRF.
ARF, yes, yes, yes.
Yeah. So why it is changed, and what is the another word is how do you differentiate AKI?
Sir, AKI and AKD. AKD, sir, two terms, AKI versus AKD. Dr. Professor Sakuja, if you give some overview, AKI versus AKD, why the terminology changes?
Yes, yes, I'll come to that, and I also come to acute AKI versus ARF.
Yes.
The term ARF was given up because when you say acute renal failure, when you use the word failure, it implies total failure of the organ concerned.
Yes.
Whereas when you say AKI, it includes all degrees of severity of renal dysfunction. So the creatinine may have just risen to 2 milligrams per deciliter from the baseline of 1. That is acute kidney injury, and it may have risen to 8 milligram per deciliter, and the patient may be dialysis dependent, and even that is AKI. So to distinguish even minor degrees of renal dysfunction from severe degree of so-called renal failure, that is why this was modified to AKI rather than ARF. That was number one. And kidney instead of renal, so that the common man could understand, because he doesn't understand renal, but he understands the word kidney. So therefore, instead of ARF, we are now using the term AKI. That's one point.
Professor Rafiqul Alam, will you add something? Professor Alam? Professor Alam?
Sorry, I couldn't follow you. Please repeat.
Will you add something regarding the definition of acute kidney injury?
So, Professor Sakuja rightly mentioned that the previous nomenclature was acute renal failure. That was the failure only, but AKI includes the spectrum of injury from milder form to severe form, needing dialysis at the final stage. That the Rifle criteria, the acute and AKI criteria, if we combine them, it includes the milder form of injury to severe failure.
Yes,
So
sir.
starting from the decrease in urine output, rise of serum creatinine in a sequential manner. So it includes a spectrum of injury, acute kidney injury.
Yeah, Jyotir, actually, ARF, it's irreversible like that, all the people will think. But AK is reversible, but if it is not intervened properly, it's reversible. If it is not intervened immediately at an emergency, it may end up in within hours to other stage 3 AK, you may lose the patient. Even 4 or 5 patients I have lost in my ICU. Hours to other you can lose in stage 3 AK. So that's why it has to be, hit hard, hit fast rule has to be applied for acute kidney injury. Then you can.
Hello.
Manishankar.
We have a 3 postgraduate. Just Purvasha, can you tell me what are the risk factors to develop AKI, and which group of people have a more chance to develop AKI? Purvasha, please.
Hello, sir. Am I audible, sir?
Yes, you are audible. Can you get my point?
Yes, sir. The risk factors for AKI, sir. Some
and
patients
also the people, which group of people? Okay.
And why this patient develop suspected clinically AKI?
Okay, sir. So risk factors which actually predispose these patients to AKI, they are namely advanced age, can be female gender, patient with previous underlying kidney disorder, like he can suffer from CKD, hypertension, diabetes. It can have due to prolonged hospitalization, certain lung and cardiovascular disease as well. Also, sepsis is an important cause, and surgery, which I have not mentioned in this case, certain cardiovascular surgery post-op patients, they are also prone to AKI as well.
In the tropical countries, the tropical infection is very important for the development of AKI in our group. Sir, Professor Sakuja?
Yes, in the patient which we are discussing today, diabetes was one of the risk factors. This was a diabetic female.
Yes, sir.
As you will come to the discussion later, who developed urinary tract infection. So diabetes was one of the risk factors which is applicable to this particular patient. We can come back to these.
Your slides and during your presentation. We'll come in details. Okay.
As such, nephrotoxic drugs, if the patient, that should also be excluded. In the history.
Actually,
Yes,
you have mentioned in the pre-renal, renal, just can you show it again, Purvasa?
Yes, sir.
Yeah.
Sir, these are the etiologies of AKI.
You have mentioned about the drugs here, but anyway, these are also the risk factors for that also. Anyway, we have actually plan to discuss about the AKI because kidney is a very important structure to maintain the hemostasis. So, Himadri, can you just tell me how kidney helps in the hemostasis of the body?
By 2 minutes.
Homeostasis of the body.
Because we have seen lot of metabolic abnormality from the ABG. So, what is the role of kidney in maintaining the homeostasis?
Yes, sir. Yes, sir. Am I audible?
Yes. Very much audible.
Sir, the kidneys maintain the homeostasis of the body fluids, electrolytes, and osmolality and pH, excrete metabolic waste products, and secrete hormones and bioactive molecules. Coming to the fluid homeostasis, 65% of the body water reabsorption occurs in proximal convoluted tubule, and 25%, around 25% in the descending loop of Henle, and around 10% in DCT and collecting duct, which is facultative under influence of aldosterone and ADH. And coming to electrolytes, sodium reabsorption occurs in all segments of nephron except descending thin segment of loop of Henle, where the maximum reabsorption occurs in the PCT via sodium glucose, sodium amino acid, and sodium inorganic and organic acid co-transport mechanism, almost 65%. And here phosphate reabsorption also occurs along with sodium reabsorption. In thick ascending limb, sodium potassium 2 chloride co-transport occurs, and in DCT, sodium chloride antiport, and in late DCT and collecting duct, which is under influence of aldosterone. Calcium reabsorption is similar to the sodium reabsorption, maximum in the PCT, and in the DCT, it is under influence of parathermone. Potassium reabsorption occurs in proximal convoluted tubule and thick ascending limb, where secretion of it occurs in late DCT and collecting duct under influence of aldosterone. Kidney plays the pivotal role in maintaining blood pH by bicarbonate reabsorption in proximal convoluted tubule and secretion of hydrogen ion in distal convoluted tubule via two mechanisms, via H plus K plus ATPase and via under influence of aldosterone. Nitrogenous waste products like urea is freely filtered, help in maintaining corticomedullary osmotic gradient by urea cycling method and then excreted. Now, discussion of fluid homeostasis, and
I think this will be too long if we go on like this. It will never end.
Actually, you have mentioned okay, sir. You have mentioned the homeostasis of the basically fluid and electrolytes. You have mentioned about the hormones and also the calcium. Okay, thank you. Himadri. I am asking about these points, particularly AKI, Dr. Sharma from Nepal. Any comments about these things or definition and the homeostasis of the renal part? Dr. Sharma, are you here?
Yes, sir. Thank you very much. Actually, basically, you know, this is a filtering organ in the body, and Professor Sakuja sir has nicely said about the AKI. And especially what I would like to mention has been already brought it to notice that if we do not intervene during early AKI, they will go into severe AKI and subsequently may have a permanent kidney damage. So that is the importance of identifying AKI at the earliest point. And for this reason also, the 0/25 group of ISN has developed an score which can be implemented in the community level or primary health center level also, and urine output can be one of the parameter which can help us to detect AKI. That is what is important of identifying AKI at the very beginning. At the same time, we can also follow the stop AKI protocol, that at the very beginning in the emergency or in any situation, we can quickly screen about the stop AKI, that is S for sepsis. We need to think and treat sepsis immediately, because every hour delay in sepsis treatment may increase mortality, said to be up to 10%. So it is very important. I think this case, that is what our resident is trying to hint us. Toxin is another thing. So we need to avoid those. Toxin means the drug which can be nephrotoxic also, and many times the drug dose needs to be adjusted. Optimized BP is another thing which could be hyper or acute rise in blood pressure, which can be nephrotoxic. And at the same time, it could be hypotension, which needs to be optimized. And prevent harm is, of course, identify cause, treat complication, review medication doses, review fluid prescriptions, both over and lower hydration. And it's very important to understand, especially at the very beginning of young, colleague, that AKI can increase hospital mortality manifold. Even 0.3 milligram increase in serum creatinine, which fulfills, of course, criteria of AKI, can increase manifold the mortality and outcome. Therefore, AKI is very important. Thank you, Gudas sir.
Thank you, Dr. Sharma. Now, Manishankar, you proceed.
Can I make a point?
Dr. Manish, yes, sir. Yes, sir.
Jyotirmoy,
Yes.
I am the only gastroenterologist probably around here. One point which I would like to make is that the presence of a decompensated chronic liver disease is a very important cause of acute kidney injury. We used to call them hepatorenal syndrome type 1, type 2. Now it has been amalgamated into the acute kidney injury of different types.
Yes, we will come in discussion when
chronic liver disease, do not forget.
Yeah, it is there on my slide of risk factors, liver disease.
Yes. Dr. Manishankar, you proceed with your case.
Okay, yeah, I have a question to Manishankar.
Yes, sir.
Actually, you listed only kidney, but patient presented with mental confusion. So when you see a sepsis, you have to see the organs which are affected. Shock is there, renal failure is there. But why the patient's GCS is low? Why a patient has mental alteration? There is encephalopathy as well. And in the sepsis, the prognosis always is determined depending on the number of organs affected. So
yes, sir.
You have to list out a complete diagnosis, and because it's a diabetic, you have to mention diabetes.
Yes, sir. I have mentioned diabetic on the next slide, sir. I have mentioned.
Yeah.
And actually, his blood sugar is high in the
yes, sir. On sir,
CBG.
on assessment, sir, blood sugar is high, sir. CBG was 226 at emergency.
Continue. So that's a newly detected diabetes.
No, sir. I have taken the detailed history and examination in the following slide, sir. Where is diabetic? I have mentioned it.
Yeah, if patient is a diabetic, then you have to mention it diabetic. And suppose you think of a probable cause, maybe urinary tract infection.
Actually, Manishankar, what Dr. Panda is telling you, that you have a proper diagnosis is the diabetes with sepsis with AKI. At least you have to mention that one.
Okay.
Anyway,
okay.
So just I'm going to that point again. Just one thing, Manali, can you tell me how kidney?
Okay. First, Manisha, to continue.
Yes, sir. So based on our primary impression, I have taken a detailed history and examination of the patient. On detailed history before admission in the hospital, patient have a history of fever for last 5 days that I have mentioned before, along with a lower abdominal pain for last 3 days and decreased urine output for last 2 days. On detailed history, patient complained of fever that is high grade, associated with chills, anorexia, and generalized malaise for last 5 days, but not associated with any vomiting, headache, chest pain, arthalgia, or skin rash. That also associated with a lower abdomen pain and pricking in nature and radiating to flank, associated with urgency and dysuria, but not associated with any hematuria. And for last 2 days, she noticed a decreased urine output, but that was not associated with any facial puffiness or pedal edema. On past history, patient is non-diabetic but not hypertensive, on regular oral hypoglycemic medication. She had no any other comorbidities. She had no history of any underlying kidney disease, and she had no history of any other drug intake other than these oral hypoglycemic medications.
Yeah, so I'd like to interrupt at this point. So the symptom that you have mentioned of flank pain and dysuria, along with fever, they suggest that this patient had a urinary tract infection.
Yes, sir.
Right? And subsequently, you will be coming to that in the investigations. So this patient, the urine showed pus cells and the culture was positive. And the radiological investigations showed enlargement of the kidneys, and it was suggestive of acute pyelonephritis, left more than right? So those symptoms which you have mentioned already tend to indicate that this patient could have a upper urinary tract infection, in other words, an acute pyelonephritis.
Yes, sir.
Right. So you can, based on those symptoms, you can suggest this clinical diagnosis.
Yes.
And another thing, sir, I think Professor Sakuja has already pointed out diabetes is a very important risk factor in the spectrum of renal diseases, especially AKI and DKD. So here you don't put diabetes in the past history because patient is already on OAD. Diabetes cannot be a past history. In a known diabetic, the sepsis has taken place, most probably urosepsis, and that has resulted in AKI. So it's a continuum of affair. So we can make it a type 2 diabetes with AKI, urosepsis. That also we can do.
Oh, okay.
Can I say something regarding the just organizational structures?
Yes.
So from the history presenting, he was presented very nicely, Dr. Moni Shankar, but Bhattacharya, he's wonderful. But I've got few questions which have been raised by Dr. Pandey as well. When we start presenting an history, we should start the patient's history with the present comorbidities. You may be diabetic, she may be, hypertensive, ischemic heart disease, CLDs, and then go on. This gentleman, like this non-diabetic patient and not hypertensive, presented with these symptoms. So at that time, at very beginning, very outset, we can some idea what the risk factors the patient might have, what we are leading to from the chief complaints. Same thing happens, it's not the past. Diabetes is once, it is always on. So it's not a past history, sorry. That is the thing I should catch, that I noticed, the same thing what Pandey was saying. So very beginning is to be better, so there to be no controversies, no debates about that. Very beginning, we can say it is non-diabetic, poorly controlled, you can add, or a middle-aged gentleman like this. Okay, thank you.
Okay.
Thank you, sir. Just one point, can I say something?
Yes.
Just one point that usually, the kidney disease is asymptomatic in any form of kidney disease, and especially in a diabetic kidney disease. So when we talk about kidney, I think it's very difficult to say no underlying kidney disease in our population. So I think we need to say that probably it may be no underlying disease, it may be unknown underlying disease, as we could see that in community-based study, up to 99% of the kidney disease patients are not aware about their disease process. So I think we need to be little bit careful about this history.
Yeah. Can Dr. Mani Shankar tell us what was the duration of diabetes in this patient?
Sir, her family member said around 5 years. Sir.
5 years. That's I asked that question because of Dr. Sanjeev Sharma's comment. So if she had diabetes for only 5 years, she may not necessarily have diabetic nephropathy. Yes, but if it was much longer than that, then she could have underlying diabetic nephropathy as well. So the duration of diabetes is an important point that you should always mention in such a patient.
Okay.
Don't leave that out. Okay.
Okay.
Go ahead.
Okay.
Yes, go ahead. Go to your next slide.
Okay.
Next slide.
Sir, on detailed examination, the higher function status was poor that have been examined on the emergency. Clinically, there is no petal edema or facial puffiness. Weight is 62 kgs. Build was average. Nutrition not adequate. Clinically, there is no pallor or cyanosis, but costovertebral tenderness is present. And I have examined the costovertebral tenderness because of his history of typical fever and the flank pain. And on systemic examination, does not reveal any other abnormalities.
There is nothing. So go ahead. Go ahead to the next one.
On investigations, after admission, patient was shifted to the medicine ward and fluid challenge test was done, along with basic oxygen support and initial empirical antibiotic support, correction of electrolytes because of this hyperkalemia. Urine output was monitored, maintaining the intake output chart. Along with, we have monitored vitals, monitoring the volume status, and particularly look for development of any features of volume overload.
At this point, I just like to stop you briefly. So, somebody had shown a slide of pre-renal, renal, post-renal failure.
Yes, sir.
Right? So, what kind of AKI does this patient have?
Sir,
possible.
Whether it is pre-renal, renal, or post-renal.
Sir, according to the presenting history, sir, I have been suspected that it may be a pre-renal AKI because of the sepsis due to decreased in effective circulatory volume. But it can be also due to renal because if renal AKI it is persists for a sustained time, it can produce some ischemic acute tubular injury like picture.
So just a minute. Why do you say this is pre-renal? You have told us that the creatinine when this patient came was very high.
Yes, sir, 6.2.
6.2 or whatever, 6.8. So in pre-renal azotemia, do you get a creatinine of that level?
No, sir.
And besides that, it is something very obvious. This patient, as you have already told us, I've gone through all your slides, this patient ultimately required dialysis, isn't it?
Yes, sir. Yes, sir.
So how can you call it pre-renal azotemia? Do patients with pre-renal azotemia require dialysis?
No.
He has mentioned, sir, he has mentioned renal with a pre-renal component.
No,
because there is no volume overload.
No. Once the patient has already gone on, when you call it renal, then pre-renal is already over. It
is excluded initially. Yes.
Yeah, pre-renal is already, that phase is already over once you have gone on to the renal damage, intrinsic renal damage.
Yes.
I hope the resident is clear about that.
Okay, sir.
Dr. Mani Shankar, sorry, go on.
Yeah, the next point I'd like to make is we also classify patients according to the amount of urine output. So how would you classify this patient?
Sir, there is only 30 ml of urine output occurred, and so according to the urine output, it can be the stage 3 AKI.
Yeah, so this you can have oliguric AKI and you can have non-oliguric AKI. Yeah, so this is obviously a oliguric AKI, as you correctly said. this could be stage 3 AKI.
Stage
We'll come to that staging a little later. And is there any other way of classifying AKI?
Sir, according to the creatinine level.
We'll come to later. That is again staging.
Okay, sir. Other ways, sir, according to the causes, medical causes, surgical causes.
Yes. So this can be called a medical cause of AKI, right? This is not a surgical or an obstetric.
There are many more classifications. Some say community acquired AKI, hospital acquired AKI.
In fact, I was coming to that only. This is what I was asking him. So this is a community acquired AKI. The other type is a hospital acquired AKI. Right? This is not obviously this did not develop in hospital. This developed in the community, and after that the patient came to the hospital. So this is a community acquired AKI, which is much more common in the tropical countries. Whereas in the Western countries, in the developed world, it is more commonly a hospital acquired AKI. Right?
Yes. Definition, if AKI developed within 48 hours of admission, it is basically community acquired. If developed after 48 hours, it is most likely hospital acquired AKI.
Hospital acquired, yes. So these are the points I wanted to make. So this is a community acquired infection. This is a oliguric AKI. This is a medical cause of AKI, right? And is it a functional injury or a structural injury?
Yes, very important issue. I was supposed to ask you this question: how the resident will differentiate from the clinical presentation and initial investigation whether it is a functional impairment versus structural injury. Very important issue, sir, raised.
Sir, possible, sir, structural injury.
Yes, you're right. You shouldn't be hesitant about saying that. Most probably, this patient has acute pyelonephritis. Right? There may also be a component of acute tubular necrosis because of the septic shock. Right? So therefore, there is bound to be structural injury in this patient. It is not just functional injury. Functional injury can be there in prerenal azotemia and rarely in other causes also. But in this patient, I would suspect a structural form of injury to the kidneys, which is responsible. Okay? Right. Go ahead. Go ahead with your
slides.
Okay, sir.
Yeah, go ahead. It will take a long time.
Sir, after initial management, renal function test was repeated after 12 hours and the 24 hours, which shows the increasing trend of urea creatinine along with the potassium level.
Yes. Go ahead.
Other investigations done along with this time, and urine analysis shows the pus cells present 10 to 12 per high power field along with the positive granular cast. Urine culture also shows
would you expect only granular casts or some other kinds of casts in the urine in this patient?
Sir, other casts can be also present, like sir, the tuber.
Don't you expect WBC casts?
Hello.
Sir. Hello. I would have expected leukocyte cast.
Sir, am I audible?
WBC cast. Yes.
WBC cast, yes, sir.
Yes, because
yes, sir. We can expect.
Because they are a polymer infiltration, because it's a septic injury.
Yeah, this is septic injury. There is acute pyelonephritis. The culture has turned out to be positive. So I would have expected WBC cast rather than just granular cast. Granular cast can be a feature of acute tubular necrosis. You get dirty brown granular cast. Whereas WBC casts are a feature of acute pyelonephritis. Yes, please go ahead. Go ahead.
Sir, urine culture and sensitivity shows a colony count of 75,000 colony forming unit per ml of the urine sample, which shows a gram-negative growth, and that was sensitive to meropenem, imipenem, and the amic acid.
Okay.
Radiological investigation, ultrasound will shows Cortical right kidney is 10 centimeter and left kidney is 9.7. With increased cortical echogenicity, the corticomedullary differentiation was maintained, and swollen kidney both left and right, but left is both more than right, with focal change in the echo texture. Plain CT scan was done, and which also shows a diffusely swollen kidney left more than right.
Yes. So these tend to confirm the diagnosis of acute pyelonephritis, right?
Yes, sir.
Go ahead. Yes.
Other blood investigations of the blood culture and the fever profile was done, and which does not reveal any growth, and
all negative.
All negative, and CRP was 6.4. Digital chest X-ray also does not reveal any abnormality.
Next slide.
After initial management, even after the adequate and he was considered for the vasopressor support and monitoring her vital parameters closely. On close monitoring, there is no improvement in her sensorium, with an increasing trend of serum creatinine along with the serum potassium. Urine output is only around 350 ml over 24 hours, and patient shows features of volume overload gradually.
So did you give her any vasopressors?
Yes, sir, vasopressor was given.
What did you give?
Sir, noradrenaline.
Norepinephrine. Yeah, that is the first vasopressor that one would consider. If norepinephrine alone you require a very high dose, then you may add vasopressin. So that will be the number 2 vasopressor that you would use in this situation. Please go ahead. Next slide.
Okay, sir. Due to development of this metabolic and the uremic complication, patient was planned for the intermittent hemodialysis, though it cannot be started for the first 24 hours initially due to the poor vitals. And after correction of the hemodynamic status, hemodialysis was started and was given slowly over a prolonged period of the time with close monitoring of her vitals.
What kind of dialysis did you do? You have not clarified that.
Sir, we have given those slow intermittent dialysis, SLD.
SLED.
SLED.
Yeah,
SLED.
so you should state that clearly. You have done SLED, that is the full form of which is slow, low efficiency dialysis. Right? So don't say just hemodialysis, because then it doesn't clarify what form of dialysis you did. Right?
Okay, sir.
That would. And what was your vascular access?
Sir, vascular access by internal jugular vein.
Yeah, so you need to specify that. The standard, that is the standard form of vascular access that you use when you have to do an urgent dialysis. So you should put in an internal jugular double lumen catheter and use that for any form of hemodialysis. Whether you do conventional hemodialysis or you do SLED, you use that as your vascular access.
Yes. Sir,
right?
Sir, Professor Sakhuja, sir.
Yes, please.
Yes, in this context, I would like to request you if you would enlighten us something about the stages of AKI, their management on a stage-based way, and also what are the problems of overzealous fluid management, if you would say something.
Yes, I did not do that because I have not yet projected my slides, and the slides will clarify the stages. Yes, but regarding fluids, what I'd like to say is it's very important to assess the hydration status of the patient when the patient first comes in. Like this patient was severely dehydrated. So, and of course, sometimes you may have a patient who is in fluid overload. And in that situation, it's very important to ensure that you don't give more fluids. In fact, you may need to do an urgent dialysis, particularly if the body weight is more than 10% above the baseline. Don't give any more fluids, and you need to do an urgent dialysis and remove the excess fluid by ultrafiltration. Otherwise, you may lose the patient. You may cause mortality. You may be too late in removing that excess fluid, and because of pulmonary edema, you may lose the patient.
So, sir,
that is
you
the
would
important.
say that we would directly go to renal replacement. Now, what is the position of diuretics in this scenario?
Yes, that's an important question that you have raised. After fluid repletion, if the blood pressure also comes up to the normal level, then yes, if the urine output has not started by itself, I would give a bolus of a loop diuretic. So either furosemide or torsemide, I would give a bolus and see if over the next 2-3 hours, if the urine output improves. And if the urine output improves, that's a good sign. But I would not repeat the bolus of loop diuretic if the first bolus has no effect. So this bolus should be given only if the blood pressure has been restored to normal and sufficient fluid repletion has been carried out. So a bolus can be given and the effect seen over the next 2-3 hours. If it doesn't work, then there is no point in giving repeated boluses of the diuretic.
Another question is from me.
Thank you.
Okay.
Yeah, please.
My question is that the fluid are replaced with normal saline, which is crystalloids. But it would be better if we could start ringus lactate, because normal saline may cause hyperchromic metabolic acidosis in this setup in sepsis as well as AKI patients. It is presumed that ringus lactate may cause little bit raise in the potassium, but there are a few studies they have seen that it's not that much harmful as the sodium chloride or normal saline is. So what is the comment from our nephrologist groups? So do you suggest normal saline or ringus lactate as a fluid to replace the hypovolemia or low hypotension? Thank you.
Yeah, we have to remember the potassium also.
Yeah, that's what I'm saying.
So initially, I would always use only normal saline. Yeah, I would use only normal saline. At a later stage, or if you have to use large volumes of saline, yes, then you may get hyperchloremia and hypernatremia, in which case you may change the kind of fluid that you're using. However, initially, particularly in this patient, there was already hyperkalemia and acidosis, and the acidosis would also worsen the hyperkalemia. So in the initial phase, I would use only normal saline. At a later stage, I may consider using other kinds of fluid.
Sir,
Dr. Sanjay, please. Sir.
Actually, thank you, Sakuja sir and Nandini madam for asking this question on furosemide stress test, which I think is very important in our context also. But sir, this patient had to wait 24 hours to get in dialysis because of hemodynamic instability or low blood pressure. Sometimes this could be fatal because this was an almost emergency indication for dialysis. Would not you suggest this patient to start peritoneal dialysis instead?
Yes, that's an interesting question.
Yes.
What I would like to say is that in this patient, since the blood pressure did not improve and SLED had to be done, I would not have given a diuretic. I would have done the SLED as even earlier than it was done. Why should we wait for 24 hours? I would have done it much earlier. Now coming to peritoneal dialysis. Peritoneal dialysis is the first kind of dialysis that we used to do when we were students for such patients. However, currently it has gone out of fashion. That's how I would put it. But that is not to say that it cannot be done. It certainly can be done. And wherever facilities for hemodialysis or SLED are not available, peritoneal dialysis can still be considered.
Sir,
So
we are using CRRT, continuous renal replacement therapy in our ICUs. The people
Yes,
who are having hypotension, we are putting them to CRRT. That can be done in view of the low blood pressure.
Yes.
Yes, but I'd like to comment on that also. See, I have made my comment on PD. So my comment on that I'd like to emphasize is, yes, PD, peritoneal dialysis can be done. I have nothing against it. But I'd like to also clarify that most hospitals in India, at least, are not doing peritoneal dialysis, are doing SLED. Now, for comment regarding CRRT. Now, while CRRT is being done in some private hospitals which have the facility, CRRT in the Indian setting, I would not recommend. It is extremely costly. The equipment itself, firstly, is very costly, not available in many hospitals. It requires replacement fluid, which is extremely costly. It has to be performed for over 24 hours at a time. It requires large amounts of anticoagulation and ideally citrate as an anticoagulant instead of heparin.
Citrate.
And it requires intensive nursing and medical care. And therefore, in the Indian setting, in any developing country, I would recommend SLED rather than CRRT. And in our own setup also, we are regularly doing SLED, whereas it is very rare for us to do CRRT. We have CRRT, but only once in a while do we do CRRT, whereas we do SLED almost every day. So I'd like to emphasize that point, that SLED is much cheaper and much better for the developing world than CRRT.
It doesn't cost much, sir. In SCB, we have almost 8 CRRT machines in different ICUs. And they marginally the fluid is costlier and the machine is around 18 lakhs and not that costlier. As you told, this SLED is preferred, but many sick patients in ICU who are also on ventilator comfortably, and the CRRT is giving result.
Yeah, but you need a specialized machine. As you said, it cost 18 lakhs. The SLED can be done using a machine which also does conventional hemodialysis. You don't need a separate machine.
Yes.
Sir, Professor Sakuja, I have a question that in this case, the resident or the unit has not done testing of any biomarker. So what is the situation where the resident will ask for the biomarker testing to establish the diagnosis of AKI?
Yes, I have a slide in my presentation which you will see a little later.
Okay.
So, see, biomarkers, after the troponins were described as biomarkers in case of acute myocardial injury, there was a lot of hope that some such biomarkers will become available for acute kidney injury as well. Just like we have troponin T and troponin I for myocardial injury. But this was a simplistic belief. See, in as far as the heart is concerned, you have just one kind of tissue which is being injured, and that is the myocardium. And so it's possible to have a biomarker. In AKI, you have the glomeruli, you have blood vessels outside the glomeruli, you have tubules, you have the interstitium, or you can have damage to a combination of all these. So it was unrealistic to expect one biomarker to be able to diagnose AKI. And although research into biomarkers has gone on for the last 2 decades, there is still no progress, not a single biomarker that can be applied for clinical use at the present moment. And I do not think that in the near future we are going to have a biomarker that is clinically useful. I'm aware of the the numerous biomarkers like KIM1 and IL-18 and NGAL and so on, and cystatin C and so on. There are so many of them, but none of them is clinically applicable at the present moment. That is the bottom line.
So, literature claim two issues. One is the biomarker raised before the creatinine become elevated, so it can help in early diagnosis. Another, it can predict the prognosis whether AKI will lead to the CKD. What is your comment? How much it is practicable?
No, I don't think so. Biomarkers like cystatin C can be used for an early diagnosis of AKI. To that extent, yes. But even cystatin C is not routinely available in all labs. And as far as predicting the prognosis is concerned, I don't think biomarkers are very useful.
So many questions are coming in chat box. So quickly finish the case. Then we'll go to the presentation.
Yes.
Then the question answer. Okay. Please finish your case.
Yes, please go ahead.
So proceed. Go ahead.
We can hear Manishankar.
Manishankar,
you are not audible.
Manishankar, unmute.
Sir, am I audible?
Yes.
Am I audible?
Yes. Please go ahead.
Yes, sir. After dialysis, we have followed the laboratory parameters after 48 hours, 72 hours, 5, 7, and the 10 days, and which shows a slowly decreasing trend of her renal function status, urea and creatinine level, along with the her electrolytes, the serum potassium level also decreased, along with there is an improvement of her total count in the form of sepsis.
Next slide.
So our final impression is it may be a case of a septic acute tubular necrosis, or should be called as an acute tubular injury, possibly due to the urosepsis.
Now here I would differ with you. Why should you call it only acute tubular necrosis and not pyelonephritis? I've already said that earlier.
Yeah.
Why do you call it only acute tubular necrosis? You have grown on an organism from the urine culture. So why is it not acute pyelonephritis?
Yeah, it's urosepsis, sir. I told the commonest cause of AKI in diabetes is urosepsis. The money you have to prove that there is no urosepsis.
No, sir, on to localize the infection, urosepsis is a broad term. So the infection of the serum to localize the infection of the pelvis.
Yes. And diabetes also to be added. Patient was diabetic.
To be
complete
diagnosis.
Complete.
Yes.
With diabetes, with uveitic encephalopathy in a patient with diabetes. So diagnosis is right in a complete fashion.
Yeah.
Okay.
He can write UTI, urosepsis is fine. And AKI, should ATN be there in the diagnosis, or we should put AKI?
No.
I would put pyelonephritis. I guess that is the most appropriate diagnosis.
Yeah. I would not put acute tubular necrosis there.
AKI.
It would be AKI.
Type 2
AKI is
diabetes,
fine. Yes.
Type 2 diabetes with urosepsis with AKI is the
final diagnosis. With
that is fine.
Everything goes for acute pyelonephritis. Very clear.
Yes.
Yeah, broadly, broadly urosepsis includes from upper or lower urinary tract infection. So both can be
there. Yes.
Included.
Yes.
So Dr. Manishankar, you have finished your presentation?
Yes.
Dialysis support. Yes.
On dialysis support, just sir, this is the last slide, sir. We just on the clinical follow-up along with the improvement of the laboratory parameters. Patient also regained her consciousness gradually after 5 days. Urine output also increased gradually. Intermittent hemodialysis is continued along with monitoring of all her laboratory parameters. And 3 weeks after intermittent hemodialysis support, patient became clinically stable and advised to attend.
No, was she taken off hemodialysis or not?
Sir, after 3 weeks of this lead support, patient is clinically stable and her urea creatinine is also down to the line, and he was went off from the dialysis support.
So creatinine, the creatinine returned to normal.
Yes, sir.
Without now off dialysis.
And patient was advised to attend the nephrology department after 3 months with repeat renal function test report.
Yeah, this follow-up after 3 months after discharge is important to make sure. Yeah, make sure that the patient does not have irreversible renal damage.
Yes.
Yes, sir.
Yeah.
One question
So
yes,
that's
ultimately
important.
land up with the CKD. So
Yeah, that's the importance of that 3-month follow-up. And this patient, you would have done SLED only for the initial period when the blood pressure was unstable. Subsequently, I think you should have done only conventional hemodialysis.
Conventional hemodialysis, yes.
Yes. Okay. So those points are now clarified. So can we now go ahead with my presentation? Yes, Dr. Paul.
Yes, sir. Yes, sir. Yes.
You put such slides.
Sir, before
Yes,
presentation, can I ask a question to Professor Sakuja, sir?
Yes,
sir,
Sir,
sure.
is there a correlation between the GFR and the creatinine? Because many times we are following the CKD 5, 4, 3, 2, 1. And many times we have in small rural setups, we don't have a eGFR calculation. So we are doing a creatinine, which is 1.4 or 1.8 or 3.2 like this. So like A1C and the blood glucose, we have a conversation chart. So any conversation between creatinine and eGFR?
Yeah, you can. There are on the net, there are sites available from where you can calculate the eGFR by putting in the parameters of the patient. So you can do that. You can do that. That is possible.
Hello.
Manishankar, you stop sharing. Just
on-share. Manishankar on-share.
Manishankar, stop করে দাও, বন্ধ করে দাও, যে স্যার করবে।
Okay, sir. Okay, sir.
তুমি স্যার স্লাইডটা দাও, এরপরেই তো আছে।
হ্যাঁ স্যার,
তো লাগিয়ে দাও, দেরি করছে কেন?
স্টপটা তো তোমার নিচে, বুঝছো?
এই তো এসে গেছে।
এটা ফুল স্লাইড করো, ফুল স্লাইড করো।
Yes. Now, okay, can you stop there? Yes. So I'll get started now, and I'll go a little fast because many of these things you already covered.
Discussed.
So until some years ago, the definition of AKI was very vague. In fact, all it included was that there was a sudden decline in renal function occurring over hours to days, resulting in a rapid rise in urea and creatinine levels. And this was with or without a decrease in the urine output. And there was no staging of AKI that was available. So this was the old definition. However, in 2004, may you go on to the next slide, please? Yeah. In 2004, we had the rifle criteria that came out, but these were soon replaced by the AKI criteria, and these were then modified by KDIGO, which is Kidney Disease Improving Global Outcomes. So this was then the revised staging and definition of AKI, which we are currently using. So there were 3 stages in this, and this staging was based on the serum creatinine and the urine output. And to stage the patient, it was important to know the baseline creatinine and for the baseline serum creatinine to be normal. Because if the baseline serum creatinine is normal, then it means you have AKI superimposed on CKD, which is not pure AKI. Now, these criteria should be applied after fluid repletion if indicated, and the patient should be staged according to the most severe criterion which he fulfills. For instance, if a patient is anuric, he is already in stage 3, irrespective of the serum creatinine level. So the most severe criterion should be taken into account while staging the patient. And the difference between AKI and RPRF, we have already covered this sometime earlier, so I won't repeat it. Please go on to the next slide. Yes, so this is a list of some of the important risk factors that we have been talking about. This is not a complete list. There can be others as well. So AKI is more likely in the elderly, more in males, more in diabetics, more common in patients with malignancies, both because of the direct effect of the malignancy and because of the chemotherapies that are used. Chronic liver disease has already been referred to. Cardiovascular disease, another risk factor. Chronic kidney disease and proteinuria are also risk factors. Cardiac surgery as well as all other kinds of complex surgery are risk factors. And finally, sepsis is a risk factor, as it was in today's patient. The next slide, please. Yes. Now there are several classifications that are currently in use. We have already discussed this. So this is one of the oldest classifications and also helps us to understand the pathogenesis of AKI. So you can have pre-renal injury which precedes intrinsic renal damage. In fact, if the pre-renal injury due to hypotension is corrected rapidly, you can prevent intrinsic renal damage and reverse the process even before intrinsic renal damage takes place. So right at the stage of pre-renal azotemia, you can reverse the process. Post-renal injury is due to intratubular or ureteric obstruction. Then we've already talked about community-acquired versus hospital-acquired injury. And hospital-acquired injury may occur in the ICU setting or in the non-ICU setting. In the ICU setting, up to 30% of patients may develop AKI as a result of hospital-acquired reasons. May I have the next slide, please? This is yet another classification which we referred to earlier. So medical causes account for about 2/3 of all patients with AKI. They include sepsis, intravascular hemolysis, drugs causing acute tubular necrosis or interstitial nephritis, snake bite, and certain infections like malaria and leptospirosis. Surgical causes account for about 1/3 of all patients. These include post-operative AKI, trauma of various kinds, and obstructive nephropathies. And finally, obstetric causes, which are very uncommon in the Western world, still account for about up to 6% of all AKI in India. And these are usually due to septic abortions, preeclampsia, abruptio placentae, postpartum hemorrhage, and puerperal sepsis. May I have the next slide, please? And this is the classification to oliguric and non-oliguric forms of injury. In oliguric injury, the urine output is less than 500 ml per day, whereas in anuric injuries, the urine output is less than 100 ml per day. And anuria occurs in patients with urinary tract obstruction, acute cortical necrosis, crescentic glomerulonephritis, thrombotic microangiopathies, and in the rare instances of mucormycosis. Non-oliguric AKI is characterized by less severe injury, lower mortality, and a much lesser need for dialysis. In patients who have wide variations in the urine output from day to day, the one possibility that you need to keep in mind is an obstructive nephropathy. May I have the next slide, please? And this is yet another important classification into functional and structural lesions. So you get a functional problem in patients with prerenal azotemia, in some patients with hepatorenal syndrome, and when you're using drugs such as ACE inhibitors or non-steroidal anti-inflammatory drugs. However, there is a wide variety of structural lesions that can be associated with AKI, and those are listed on this slide. Of these, the commonest by far is acute tubular necrosis, which accounts for more than 60% of all patients with AKI. Not to say that the others are not important. Acute tubulointerstitial nephritis, largely due to drugs, rapidly progressive glomerulonephritis and vasculitis, acute cortical necrosis, hemolytic uremic syndrome, tumor infiltration, cast nephropathy, and crystal nephropathy are the other forms of structural injury that you can encounter in AKI. The next slide, please. Yes, how does AKI in the tropics differ from that elsewhere? Firstly, the etiologic spectrum is quite different. We have a wide variety of infections such as leptospira, dengue, scrub typhus, and so on, falciparum malaria, which can contribute to AKI. We have obstetric causes, which the developed world does not see. We have etiologies such as snake bite. So therefore, we have a wide variety, and even within the tropics, there is heterogeneity in the spectrum. AKI in the tropics is commoner as compared to the non-tropical regions, so accounting for 1.5% of all hospital admissions, as compared to only 0.1% in the temperate zones. Community-acquired AKI is commoner in the tropics than hospital-acquired AKI. The mean age of patients is much lower, 34 years as compared to 60 years, and patients tend to come to the hospitals very late in the course of AKI. May I have the next slide? Yeah. When you see a patient in the emergency, it's important to distinguish AKI from chronic kidney disease. So these are the parameters that can help you. The history, of course, any preceding history of hypertension or a long history of edema or frothuria or proteinuria would suggest to you chronic kidney disease. The presence of a normocytic normochromic anemia would be a point in favor of chronic kidney disease. The finding of half and half nails also favors chronic kidney disease. Similarly, peripheral neuropathy, mineral bone disorder, small kidneys on an ultrasound, and the presence of left ventricular hypertrophy on ECG or echocardiography would all be features that would suggest chronic kidney disease. The next slide, please. Yes, we've already referred to the urine sediment. So the presence of numerous RBCs and RBC casts along with proteinuria would suggest glomerular disease. WBCs and WBC casts, as in the patient we discussed today, would suggest pyelonephritis. the presence of brown granular casts and lot of tubular epithelial cells would suggest acute tubular necrosis, and the presence of crystals would suggest a crystal-induced nephropathy, which can occur with certain drugs or poisons, and the presence of broad casts would suggest chronic kidney disease. Now, what kind of visualization do we use in AKI? The most important investigation is an ultrasound. The main purpose is to exclude urinary tract obstruction and to exclude contracted kidneys, which would favor CKD. So in most patients with acute tubular necrosis, the kidney size would be normal. A CT scan is only rarely required in certain types of AKI like obstructive uropathies or emphysematous pyelonephritis. You don't require it in every patient with AKI. The next slide, please. Yes. Now, this slide shows you the urinary indices, and sorry for the slight movement of the headings here. The column to the left shows you the values in pre-renal azotemia, whereas on the right are the values in patients with acute tubular necrosis. So I'd like you to focus on the osmolality in the urine, which is high in case of pre-renal azotemia, whereas it is 300 only in patients with acute tubular necrosis. The urine sodium is low in pre-renal azotemia, whereas it is high in acute tubular necrosis. We've already talked about the urine sediment. And the important thing with pre-renal azotemia is that it responds to a fluid challenge, whereas acute tubular necrosis generally does not respond. One other important feature is that the urea is increased out of proportion to the creatinine levels in pre-renal azotemia, whereas that is not the case in acute tubular necrosis. The next slide, please. With regard to the biomarkers, I think I've already dealt with that, so I won't repeat that. At the moment, none of the biomarkers is very useful. Next slide, please. Yeah, so these are the phases of acute tubular necrosis. Now I'll cover acute tubular necrosis in a little more detail than other forms of structural injury, since this is the commonest variety. So the initiation, this is divided into 4 phases. The total course may range from just a few days to up to 8 weeks if the patient does not recover early. The initiation phase lasts just 24 to 48 hours. The oliguric phase can last for up to 3 weeks, as it did in the patient we have discussed today. The diuretic phase usually lasts about 1 or 2 weeks, and after that, the patient quickly recovers from the injury. The next slide, please. And this shows you why patients become oliguric in acute tubular necrosis. In the initiation phase, it is because of the reduced renal blood flow and therefore the reduced glomerular filtration rate. Subsequently, it's a consequence of tubular obstruction by the desquamated epithelial cells and casts in the tubular lumen. There is also rupture of the tubular basement membrane, that is tubulorhexis, as a result of which there is back leak of glomerular filtrate into the interstitium of the kidney, and as a result of that also oliguria is caused. The next slide, please. Yes, now coming to the management. So as was done in this patient, when the patient first comes in, you have to assess the blood pressure and the volume status, carry out fluid repletion, give a loop diuretic after fluid repletion and blood pressure normalization. You may use vasopressors if the blood pressure does not normalize after fluid repletion. You keep monitoring the body weight and the urine output throughout the oliguric phase and ensure that the fluid intake is given depending upon these two parameters. You look for hyperkalemia, acidosis, pulmonary edema, since these are all immediate indications for dialysis. As far as nutrition is concerned, ensure that the protein intake is between 0.8 to 1 gram per kilogram in a non-catabolic, non-dialysis patient, whereas in catabolic or dialysis patients, you need even more than that. Drug doses, particularly antibiotic doses, need to be modified according to the GFR. And of course, you treat the primary disease, which is the cause of the AKI, like if the patient has acute pyelonephritis, as in today's case, you give antibiotics. If the patient has malaria, you treat the malaria, and so on. So treating the primary disease is also very important. Next slide, please. Yes, just quickly to recollect how you treat hyperkalemia. So if there are ECG changes of hyperkalemia, you use calcium gluconate. This is to antagonize the cardiac effects. If those changes are not there, this is not required. The next step is to give 10 or 25% dextrose along with the insulin intravenously. And this ensures a shift of potassium into the intracellular compartment and thus reduces the potassium levels. Next step you can use is nebulized salbutamol, which also helps in shifting potassium into the intracellular compartment. You give intravenous bicarbonate only if the patient is also acidotic. You can give a loop diuretic to increase the urinary loss of potassium. You ensure that the dietary intake of potassium is restricted, and rarely you may need potassium binders and a laxative. And if all these measures don't work, then of course you need to go on to dialysis. The next slide, please. Now, what are the urgent indications for dialysis? So these include hyperkalemia with a potassium of more than 6, metabolic acidosis with a pH of less than 7.15, pulmonary edema, and encephalopathy. And it has been shown many years ago that prophylactic dialysis, by preventing mortality due to these complications, can improve survival. So therefore, even though there is no consensus on the degree or duration of azotemia or oliguria, if the urine output is less than 200 ml for more than 12 hours or 100 ml over a period of 8 hours, I would go ahead with the dialysis so that I don't end up with a patient developing hyperkalemia or metabolic acidosis or pulmonary edema. If there is fluid overload, as evidenced by a more than 10% increase in body weight over the baseline, this would be an indication for immediate dialysis, because this fluid overload can cause mortality. And as we've already discussed, the internal jugular vein is the appropriate vascular access for dialysis. The next slide, please. Yes, so the dialysis modality that I would use for a hemodynamically stable patient would be conventional hemodialysis done thrice a week, 4 hours each time. For a hemodynamically unstable patient, I would do SLED in preference to CRRT. And peritoneal dialysis, which was asked about, yes, I've already stated peritoneal dialysis in places where hemodialysis is not available and in small children. Yes, this is an appropriate kind of management. And we'll continue dialysis till the patient goes into a diuretic phase. The next slide, please. Yes. Now coming to the question of renal biopsy, if you're suspecting typical ATN, then a biopsy is not required because the patient is going to recover spontaneously in due course of time. However, sometimes you require an early biopsy, and that is when the cause of acute renal failure is not obvious. For instance, you have a suspicion of RPGN or vasculitis or drug-induced acute interstitial nephritis, then specific therapies are urgently required for these forms of AKI, and therefore an early renal biopsy is indicated. And in patients who do not improve despite more than 3 weeks of oliguria and dialysis dependence, you need to do a biopsy to exclude acute cortical necrosis. The next slide, please. And this is just to briefly tell you about the histologic findings in acute tubular necrosis. So the tubules are usually dilated in these patients and lined by flattened epithelium with cell debris and casts in the lumen and some degree of interstitial edema. But tubular necrosis is a misnomer because necrosis is seen in only 10 to 15% of the tubules. And therefore, it's said that it should be called acute tubular injury rather than acute tubular necrosis. Mitotic figures can be seen as evidence of tubular regeneration in the tubular epithelial cells. The next slide, please. The mortality of AKI ranges from 20 to 70%, depending on the underlying cause. The GFR returns to normal after recovery in only about half of all patients and may take several months to become normal. The prognosis depends on several factors, including the age of the patients, the cause of AKI, the presence or absence of oliguria, the severity of AKI, the presence of sepsis, the number of failed organs, and the comorbid conditions that the patient has. I don't have too many slides left, so
yes,
we finish.
Yes, sir. Thank you.
The question, yeah, just next slide. I just have 3 slides left. That's all. Nothing.
AKI to CKD, very important slide.
Yeah, AKI to CKD. We have already mentioned this. Do patients who have recovered from ATN go on to develop CKD? Well, the answer to that is yes. Some of them may develop that. How many exactly? This is not known. This could be variable, and we do not fully understand the mechanisms responsible for this. So patients who do not recover within 7 days of AKI, they are the ones who are referred to as AKD or acute kidney disease. And these are the ones in whom we should check the creatinine 3 months after discharge. And if it is still not normal, then they would be labeled as CKD, right? And then they may require investigation. And may I have the next slide? Yes, just a brief word about acute cortical necrosis. This is a rare kind of injury that we do see in India still. Obstetric causes are the most frequent cause of this, responsible for almost 60%. These are usually septic abortion, abruptio placentae, preeclampsia, and puerperal sepsis. Non-obstetric causes include snake bite and hemolytic uremic syndrome. The vast majority of these patients do not recover from AKI. They go into end-stage renal disease. And the last slide. Yes, I felt my presentation would be incomplete if the students go away without knowing about myeloma as a cause of AKI. Now, this is an important cause of AKI, particularly in the elderly, which is often missed. And one should remember that renal failure is a presenting manifestation in 10% and occurs sometime during the course in nearly half of all patients. So in all unexplained renal failure, particularly in the elderly, look for myeloma. Disproportionate anemia and hypercalcemia are other clues to the diagnosis of myeloma. And if you suspect it, always get a serum protein electrophoresis and a free light chain assay done. The most common lesion in such patients is a cast nephropathy. And besides dialysis, of course, plasma exchange and high cutoff dialysis are maybe useful treatment modalities that can be considered in such patients. So don't forget about myeloma when you're dealing with AKI. Thank you very much indeed.
Thank you, sir. Thank you, sir. We got many answers. Initially, we raised, particularly myself and Professor Udas was raised the question, what is the difference of terminology between AKI, AKD, and CKD? Basically, this is a spectrum. Start with AKI, land up with AKD, then land up with CKD. So, yes, sir. We are involving students also. So, one student, Dr. Manali, is connected with us. Manali sir has many times in his management has mentioned that correction of the metabolic abnormality is very much important. Acidosis, then hyperkalemia. Sir, can you briefly by 1 minute, what are the how the kidney disease affect the homeostasis of your body? What are the metabolic abnormality we face in kidney disease?
Sir, am I audible?
Yes, you can say even without slide.
Okay, sir. Sir, basically there are 7 metabolites that are becoming abnormal in any AKI patient, and those are, sir, sodium, potassium, phosphate, acidosis or H+, uric acid, and magnesium. Sir, out of these, any increase or decrease of these are possible, but the more common ones I will say, that is hyponatremia, hyperkalemia, hyperphosphatemia, hypocalcemia, acidosis, and increase in uric acid, and hypomagnesemia. So these are the common things, and sir, and there are various mechanisms by which they can happen. 2 to 3 things I will like to mention is that if in any AKI patient we see disproportionately high potassium and phosphate and uric acid, then we must keep tumor lysis syndrome in mind, as well as acute hemolysis and rhabdomyolysis. And if in any AKI patient we see hypercalcemia, as Shakuja sir has already mentioned, we should always think of myeloma.
Yes, Dr. Manali. 2 metabolic abnormalities very important when dealing such a case. One is acidosis, one is hyperkalemia. Unless it is treated, can lead to different cardiac abnormality, arrhythmia, even cardiac arrest, and that is very important issue. Cardiac abnormality in AKI will come in the later part of our discussion. Before that, Dr. Mahesh is connected with us. He's a nephrologist from Kathmandu, Nepal. Sir, we'd like to hear from you, Dr. Mahesh.
Yes.
Manisha,
yes, sir.
Yes, sir.
You remove a slide.
Okay, sir.
Slide not record. Sir, in the initial classification, Dr. Mahesh, the GFR was used, but later on, when the new classification, GFR was not used. What is the fallacy of estimating GFR in normal patient, also in AKI patient? Why GFR rather than actual output was taken in consideration rather than GFR? In the rifle classification, they use the GFR, but later on not used. What is the problem with GFR?
Actually, there is some correlation between GFR and creatinine. However, the available GFR estimating equations, they are not validated. They are not valid. They do not hold true for rapidly changing kidney function. That means, like in a patient with AKI, that we cannot estimate GFR based on serum creatinine. So that must be the reason why this GFR has been dropped. And like clinical parameter, urine output is the most easiest one. Even serum creatinine lags behind the change in kidney function. Like if we have recovering kidney function, serum creatinine would like underestimate GFR, and if we have declining kidney function, serum creatinine would overestimate GFR. So that must be the reason.
Yes, sir. Dr. Sakuja, will you add something?
Yes, no, that is fine. That is the reason. In fact, it is difficult to measure GFR in patients with AKI because it is rapidly changing. It's a rapidly evolving parameter. It's not remaining the same. When the patient is developing AKI, the GFR is actually dropping. And when the patient is recovering, the GFR is gradually increasing. And there is no way of measuring the GFR accurately during these phases. And that is why the GFR parameter that was there in the rifle criteria is no longer there in the KDIGO classification.
Can I ask a question to Professor Sakuja, sir?
Yes.
Yes. Sir, in early diabetic kidney disease, the AKI due to other causes and the early DKD, what is the surest way to differentiate?
Differentiate between DKD and
AKI because of other causes, not because of the diabetic kidney disease in a early nephropathy.
Oh, but you need to specify what type of AKI you're talking about there.
Suppose somebody presents with a very slight rise in the urea creatinine and maybe features of AKI in a diabetic, where there are also other causes. Suppose IgA nephropathy is there in the background, or there is a NSAID assault is there. So can we tell it's not because of diabetic kidney disease, because of the other non-diabetic reasons?
Then you have to first look for albumin urea. I would first look at albumin urea, because if there is albumin urea and the duration of diabetes has been, say, more than 10 years, then there still may be diabetic kidney disease associated. There may be two problems. There may be diabetic kidney disease and AKI due to some other reason. So I will first look at the duration of diabetes and the presence of albumin urea. Then, for instance, you said IgA nephropathy. So I will look at the urinary sediment. That's very important. If there is persistent microscopic hematuria, that would be a point against diabetic nephropathy, and that would suggest a possibility like IgA nephropathy. So I would look at the urinary sediment. And then if there is, say, NSAID-induced rise in creatinine, so I would withdraw the NSAID and look for a fall in the creatinine level. If the creatinine level comes back to normal, then I will attribute it to possibly the NSAID. So I think I will have to individualize my assessment depending on what cause of AKI you are thinking of.
Yes. Yes, sir. So when we encounter a case of AKI, our first duty first to establish AKI, then I will differentiate the whether it is pre-renal or intrinsic cause of the AKI, or other word functional impairment or structural impairment. What the Professor Sakuja at the beginning was telling. So we have to differentiate between functional impairment versus structural impairment. Then we will go also search for the etiology, risk factors, and others.
Here, sir, I would like to ask Dr. Mahesh that would he elaborate a little bit upon dose modifications of drugs in a patient of AKI, sir?
In AKI, one of the most important components of management in AKI is adjustment of the dose and removal of the nephrotoxic drugs. That is one of the most important things nephrologists do. And regarding dose modification, it depends on the route of excretion of the drugs predominantly. If it is renally excreted drug, the dose has to be reduced. And then if a patient with AKI is undergoing renal replacement therapy, then we have to consider whether that particular drug is dialyzable or not, whether that is removed by dialysis or not. If it is removed by dialysis, then that has to be supplemented post-dialysis. That is another important consideration. Then another important consideration would be like whether you have to maintain the same dose and increase the interval, or like you have to reduce the dose along with increasing the interval. That depends on what is the more mechanism of action of that particular drug. Especially that was true for antimicrobial drugs, whether the killing is like concentration dependent or dose dependent. So these are generally the considerations.
Okay, thank you, sir. And Professor Sakhuja, would you tell us something about contrast-induced nephropathy and how to prevent it if we at all need to do it for some reason?
Yes, yeah, that's an important question. We generally try to avoid use of contrast wherever we feel there is going to be an increased risk of nephrotoxicity. However, there are certain circumstances where it may become essential and we are unable to avoid. So then the most important precautions are, number one, don't use multiple nephrotoxic agents simultaneously. In other words, don't combine contrast agents with other nephrotoxic drugs such as aminoglycosides or NSAIDs or ACE inhibitors or ARBs, etc. Number one. Number two, ensure that this is most important, ensure that your patient is well hydrated before the procedure. So if you want to be sure about hydration, best is to give him some IV normal saline. Some people have also used intravenous bicarbonate for this purpose, but normal saline is as good. And if you give the patient 1 liter of normal saline prior to the procedure, you would have adequately hydrated him. And finally, use the lowest dose of contrast that is sufficient for your investigation. So these are the most important precautions. We used to use N-acetylcysteine in the past,
yes,
but now it's no longer considered of any use. It doesn't really help.
So there are studying with use of statin and calcium channel blocker. What is your view at present?
Currently, I mean, I don't use any other agent for management or prevention of AKI in this setting. The hydration is the only important thing that I would use.
Hydration before only or before and after?
Before is much more important.
Okay. Okay.
NSAID also will be useful pre and post nephrotoxic, no sir? Before N-acetylcysteine IV infusion can be used post.
No, that's what I said. We used to use it earlier, but it's no longer considered useful. We have used a lot of it earlier.
So difference between the contrast-induced nephropathy and drug-induced, contrast-induced nephropathy develop early, also recover early. Whereas the drug-induced, it may persist for a longer.
Yes, that is true. Generally, contrast-induced nephropathy develops within the first 24 to 48 hours, and it can recover rapidly as well. It can recover.
But drug-induced, actually, the aminoglycoside half-life in the renal cells is much longer than the blood
yes.
That is why even if you stop the aminoglycoside, the renal failure, that part persists for even the weeks can persist.
Yes, it takes much longer to recover.
Much longer time.
Rifampicin-induced irreversible irreversible damage also can occur. In some cases, irreversible. Rifampicin and aminoglycoside, irreversible kidney injury.
Sir, another question came from the student: how the fractional sodium excretion can help in differentiating between the pre-renal versus intrinsic renal disease?
Yes, this was on my slide, the fractional excretion of sodium is one of the urinary indices that is used to differentiate pre-renal from acute tubular necrosis. It is one of the indices, although not very commonly used nowadays. So I would rely much more on the urine sediment examination and the response to IV fluids to differentiate the two conditions.
So another functional inquiry very important is the hepatorenal syndrome.
Yes,
So when the recipient is suspect to be the hepatorenal syndrome and how they can prevent it.
Yeah. Now, hepatorenal syndrome usually occurs in the setting of chronic liver disease, that is cirrhosis of any etiology, whether it is alcoholic or non-alcoholic steatohepatitis giving rise to cirrhosis. So generally in patients with cirrhosis, sometimes hepatorenal syndrome can develop. It is often precipitated by spontaneous bacterial peritonitis, one should always look for. It can also be precipitated by abdominal paracentesis or by GI bleed. And generally, hepatorenal syndrome is characterized by low urine sodium. And there is also, although some people think that hepatorenal syndrome is a functional form of renal failure because of renal vasoconstriction, this might not always be the case. There is a condition described which was earlier called polemic nephrosis and which is now called a bile cast nephropathy. So particularly in patients who have deep jaundice with a serum bilirubin of more than 15 to 20 milligrams per deciliter, you can get tubular obstruction by the presence of numerous bile casts. And this may be a structural lesion that is responsible for AKI in patients with so-called HRS. So one should remember this condition as well.
Thank you, sir. There are some questions in the chat box. A few of them needs to be clarified. One of these questions is that, was a fluid challenge necessary in this particular case, and how relevant it is? That is the question, Professor Sakhuja, sir, if you...
Yes, whenever a patient comes in, see, this patient was in altered sensorium. And a patient with altered sensorium will be expected to have a poor intake unless during that period of altered sensorium a RISE tube has been put in and the patient has been given fluids or intravenous fluids have been given. So I would expect such a patient to be dehydrated because of altered sensorium. And then the patient was also febrile. So this kind of patient I would expect, and then the patient was in hypotension. So the first step in resuscitation of this patient would be IV fluids. Vasopressors would come in only after fluid repletion, not as the first step. So definitely, yes, fluid repletion was required in this patient.
Okay. And there is another one, another question, that what should be the bolus dose of diuretic according to the BP levels? So you had,
dose,
yes, sir, continue.
Yeah, the bolus dose does not depend on the blood pressure levels. The blood pressure should be normal, should not be low. So according to the baseline blood pressure of the patient, the blood pressure should be normal. So if you have a blood pressure, a systolic blood pressure, which is at least around 110 or 120, I'll be satisfied with that. And the bolus dose of diuretic can be something like, if you're giving furosemide, then something like 1 to 1.5 milligram per kilogram is the the diuretic challenge that is recommended.
Okay. Thank you, sir. Should I ask the other questions in the chat box?
Yes. Because students have put their question, they should be clarified.
There's another question. What is the importance of, is there any importance of ACR and anion gap calculation in the AKI scenario? I mean,
ACR and anion gap.
Yes.
See, ACR would not be not really very important in AKI. Yes, but if you're suspecting some other form of injury, like if you're expecting that this patient also has a diabetic nephropathy, then it would be certainly important. So but I would investigate the ACR only at a later stage after the patient has recovered from AKI. Because the AKI will itself influence the ACR. So therefore, ACR will not be important at this stage. At a later stage, yes, it can be done.
Sir, another question. The one terminology is subclinical AKI. What is this?
Yeah, the term subclinical AKI has been used particularly by Claudio Ronco. And in fact, he put out a classification of subclinical AKI in 2012, but that was based on biomarkers. So he says that if you have a biomarker which is abnormal, but the serum creatinine is not abnormal, then he called it subclinical AKI. Or there may be another category of patients in which the serum creatinine is abnormal, but the biomarker is normal. So he referred to these as subclinical AKI. However, with the doubt about the validity of biomarkers, I would refrain from using this classification at the moment. I would not use it at the moment.
Okay. We have more questions in the chat box.
Yes. One of them is that, is there any role of steroids in AKI when sepsis has been ruled out?
No. When you said when sepsis has been ruled out, in fact,
that is the question. Yes.
Yeah, in steroids can be used in patients with severe sepsis with shock. Steroids could be used in that situation. If sepsis has been ruled out, then there is no role for steroids. Yeah, unless you're treating drug-induced interstitial nephritis or something, there steroids have a role. So otherwise, steroids don't have a role.
Because of Edisonian crisis, in severe sepsis, we give low dose of steroid.
And critical patient.
If it is ruled out, then why should you give steroid?
Yes. Sir, actually, you have mentioned in your cause that some vasculitis or glomerulonephritis may be there. So in that case,
yeah, that is a specific indication. Yes, that's a separate indication. I haven't at all tried to cover the treatment of those conditions.
Yes.
So that would be a totally different
their indication is immunosuppression.
Yeah, not just steroid. Yes.
Yes.
Blood incompatibility and drug-induced AKI. There is a role of steroids. Short course of steroids.
Yeah, in drug-induced interstitial nephritis, yes, steroids are indicated.
There's a question from Manali that in cardiorenal syndrome with volume overload and AKI, can diuretics be used?
Yes, certainly. Diuretics can, if there is fluid overload in such a patient, yes, diuretics can certainly be used.
But you have to do it carefully because it precipitates hepatic encephalopathy as well.
Dr. Purvasha, Dr. Himadri, Dr. Manali, you are connected. you can directly, you are in the link, you can directly ask question, one problem that you commonly encounter in the emergency. That problem you can, then again we will go to the chat box question. Dr.
Yes, sir.
Himadri?
Yes, sir. The same clinical situation, but here the CBG was 226. If the patient had presented with high CBG, that is not and with hyperosmotic state, hyperglycemic hyperosmolar state, HHS. So, how is there any change in the management will be there in this patient? And fluid
You mean
resuscitation.
AKI with hyperosmolar
CKD.
coma? That is your question.
AKI, yes, AKI in background. AKI in background of CKD with HHS. And how I will do the fluid resuscitation there.
AKI on CKD with HHS, type 2 diabetes mellitus.
Okay, sir. Yes, sir.
If the sugar levels are very high, then the only additional therapy that you require is insulin. That is the main therapy to rapidly lower the elevated blood sugar levels. The fluid management in this patient was in shock. So the fluid management will remain the same. I don't think the fluid management will change.
If already there is background, if already CKD is there also, fluid management.
Himadri, I understand your question because in a hyperosmolar, hyperglycemic state, we give a lot of fluid, maybe 4 to 5 liters. In a setting of DKD, we have to restrict fluid and you have to balance. We will give insulin infusion very carefully in an infusion pump, and you have to balance between the osmolality, anion gap, and the permissible fluid replacement in view of the renal status. Unless you balance both the part, this hyperosmolar state and the diabetic kidney disease, will be chances of one precipitating the other thing.
You have to do the HD hemodialysis also. If warranted, you have to do.
I want to say one thing, Dr. Himadri. In case of, acute kidney injury, but what about renal function compromised state, we have to be careful regarding fluid. But in case of HSS, we have to be very careful not to start insulin before correcting the fluids. Because if we start insulin before, that will cause acute deterioration of the patient, and we might lose the patient. So be careful if HSS, we should not start insulin without the fluid support. We have to adjust the fluid according to the renal status. But you have to give fluid, keep in mind, and checking the volume status of the patient as well. Thank you.
And hypokalemia can take the patient. Hypokalemia commonly.
Sir, I have a question, sir.
Yes, please ask.
Sir, commonly in the wards, what we encounter, sir, in a patient with AKI on the basis of urea creatinine reports, we also get, suppose, a few pus cells in the urinary routine examination, but the patient does not have any evidence of pyelonephritis as in this case. So can we attribute AKI due to a lower urinary tract infection?
No. How can a lower urinary tract infection cause AKI?
So that is the question. Many times there is a confusion.
No. Please stop there. What is a lower urinary tract of infection? That is cystitis.
Yes.
The infection is restricted to the urinary bladder. How can that cause AKI?
Okay, sir, if the infection is quite severe and is causing sepsis, like
you mean it will cause septicemia without causing pyelonephritis in a patient with acute cystitis?
Yes,
that would be very rare. Very rare.
There is an ascending Manali, I think in two situations, your question can be extrapolated. The first is if it's a ascending infection. Dr. Sakuja has already told a lower urinary tract infection, ascending to upper urinary tract infection and pyelonephritis that can cause, or if it's a septicemia and septic shock with hypovolemia and decreased blood supply to kidney.
Yes,
that can happen.
Can cause acute kidney injury.
Dr. Purvasha, your question?
Yes, sir. Yes, sir. I
Yes.
have a question. Sir, in a
Yes.
patient of DCM with
You on
AKI.
your video. Your video is off.
Okay, sir.
Hmm.
Okay, sir. Sir, in a patient with DCM developing AKI due to volume loss, sir, what is the management regarding this? Should we give vasopressin or vasopressors or fluid therapy in this patient, sir?
You're talking of what is DCM?
Sir, dilated cardiomyopathy with decreased ejection fraction in underlying
Yes.
cardiac disease.
Yes. What is your question?
Sir, if these patients develop AKI due to volume loss, like diarrhea or vomiting, so should we give volume fluid fluid therapy in these patients, or should we give any vasopressor? Because in this patient,
if the first thing that happened is volume loss, you have already stated that, then
yes,
you
sir.
need to replace volume. Vasopressor will come afterwards. No.
Okay,
First step will be replace volume.
Okay, sir. So I have seen.
Yeah,
sir,
that
I
is the
have
answer. Purvasha, volume loss, you have to correct the volume for the volume loss. What Professor Sakuja told, that is the answer. Don't beat the mad horse.
But you have to observe, they should not be overloaded.
Yeah, don't
actually
overload.
what Purvasa Janto,
Yeah.
what actually Purvasa is want to us that it is very difficult to patient having a rather dehydration and in a DCM with reduced ejection fraction to assess how much fluid is required. Really, it is difficult to ask also, but in a critical setting, we measure the CVP and others.
Yeah.
So main
You have to
aim of
balance.
therapy is that first you correct the fluid, and then if it is not improved, then you rather add vasopressor. First you correct the fluid, and you can assess clinically.
To keep a balance.
If the chest is not, that clear that there may be a fluid overload and the neck pain and hydration, that is the clinical, because many times you do not do the CVP measurement.
Yes.
Okay.
Thank you, sir.
You can help of the echocardiography and IVC.
Yes.
It's very important, Professor. It's a IVC collapse or dilated. Collapse means you have to replace. This DCM patient, fluid replacement with caution, and you estimate the urine output. If it is coming out very well, and IVC, it's collapse or dilated. If it is improving, that's a 12 millimeter, 13 millimeter, you stop fluid. After that, obviously you have to give. No role of vasopressors. Okay, here.
Okay, sir. Thank you, sir.
Yes. Some more question has come.
Yes. One question is how to approach a case of USG proven pyelonephritis with pyuria but repeatedly negative urine cultures.
No, I think then there is some problem with the way the urine culture has been done. I don't agree with this question at all. This should not happen.
Maybe the treated cases.
But it happens, sir, sometimes.
No. This can only happen if the urinary tract is obstructed somewhere. Otherwise, why should the urine culture be negative?
Come negative.
Unless
there's a lab error.
I think residents are bringing up theoretical situations which don't actually exist.
Sir, they may mean the abacterial pyuria.
No, sir, actually partially treated, sir.
Yes,
usually the report from the periphery, they are already given meropenem 2 to 3 dose.
Yeah, then you have to then please include that in your question. Mention all the details in your question.
Yeah.
Sir, is there a role of kidney biopsy in AKI?
In the slide.
I have covered that in the slide.
Yes.
Already covered.
Okay. And one thing is about NSAID-induced nephropathy. Which one is notorious? So this is a question from Orithro Ganguly. Which one of the NSAIDs is notorious for causing this, and how often NSAID-induced AKI occurs?
See,
an NSAID, I don't think I would say that one particular NSAID is more likely. The COX-2 inhibitors are relatively more likely, but any NSAID can cause AKI due to AIN, acute interstitial nephritis. So any NSAID, don't think that some particular NSAID is harmless. don't go with that impression. Any NSAID can cause this problem. Number two, even NSAIDs that have been consumed over a long period of time can someday cause damage. So even don't presume that since a patient has been taking it for a long time, therefore it is unlikely to cause AKI. So that is my comment with regard to NSAIDs.
To some extent, naproxen is safer. Naproxen is safer, no, sir?
Sir, to some extent, COX-2 inhibitor. Sir, COX-2 inhibitor possibly alter more prostaglandin.
Yeah,
so
COX-2 inhibitors are
more the prostaglandin inhibitor. So that can cause more NSAID-induced nephropathy compared to others.
Yeah, that's what I would say.
Should I ask? There's one more question, or is it late? There's
last question.
Okay, last question. Dr. Mahesh, sir, is he still there?
Yes, ma'am.
Mahesh? Yes.
There's
one question. If pyelonephritis had extended to form a renal abscess and it is missed in USG or NCCT, should we opt for a contrast-enhanced CT using non-ionic contrasts, since the abscess requires drainage?
This scenario again would be very unusual, because if the abscess is clinically significant and in the management, if it needs to be drained, then it is a reasonable size.
Yes.
It should be visible, and non-contrast CT also should pick it up. But then in relation to the use of contrast in AKI, then you have to prioritize. If the contrast CT is going to change the management, in that scenario, with precaution, with hydration, as Dr. Sakuja mentioned before, it has to be taken. But in this particular abscess scenario, I don't think contrast CT is required.
Is it possible?
Because like till the size of around 5 centimeters, you generally manage conservatively, and it should respond to therapy.
Okay.
Usually serial ultrasound is the answer. Sometimes first day you may be missing, third day you can pick up. Serial ultrasound or ultrasonography.
Exactly. For the benefit of the residents, like this scenario would be if there is persistent fever, persistent renal angle tenderness, post-vertebral angle tenderness, without significant pyuria. Pyuria is declining, but then there is persistent fever and tenderness, then we should be suspecting like abscess. But meaningful, clinically significant ones should be picked up by ultrasound only.
Thank
you. Professor H.S. Patel, our senior faculty and chairman of API West Bengal branch connected. Sir, any comment upon this discussion? Dr. Patel?
On your video, please.
Professor Patel is one of the first doctor to be connected.
Dr. H.S. Patel?
Yeah. When I joined, I saw only him. Professor Patel.
Dr. Patel, not there, not.
Okay. He is, he's coming.
Very nice discussion.
Thank you.
Plenty of useful information.
Thank you, sir.
Thank you. So we have discussed a lot. If there is no more question, so now I request Dr. Palaniappan, my very good friend, to give vote of thanks to all the faculties, chairpersons, dignitaries, and most important to all the students.
Yeah. Thank you very much, Jyotirmoy Paul. So, on behalf of Association of Physicians of India and Indian College of Physicians, with Association of Physicians of Bangladesh and Nepal, our heartiest thanks to Dr. Kamlesh Tiwari sir and Dr. Rajesh Upadhyay, Pankaj Saguja, and Dr. Y.P. Munjal sir not there, Professor Mohammad Rafil, and Dr. Professor Sanjeev Sharma, Professor Arafat, and Manisankar Bhattacharya, student, and all the postgraduate students, and moderated by Vinay Saguja, and Professor Dr. Arafat, Magesh Raj, and my dear friend Jain Panta, my dear friend Jyotirmoy Paul, Utas Ghosh, and Professor Nandini Satarji. It went on very well. Acute kidney injury, lot of practical tips and detailed discussion by Pankaj Ahuja. Really, all the postgraduate students enjoyed, as well as practicing physician also got many practical tips. You made the day, and postgraduate students also did very well. Lot of learnings and lot of feedback also came. And thank you very much, one and all, for the wonderful opportunity. Thank you very much.
Thank you. And everyone.